Okay. Hi, everybody. My name's Amethyst. First of all, I want to thank everyone for coming today and thank Big D's for hosting as well. I'm a physical therapist and owner of Acclivity Integrated Physical Therapy. And what we're going to talk about today is the anatomy and the function of our pelvis and how it relates to us with riding. I guess I have to come over here to get the slides going for you. Here we go. So a little bit about me first. Like I said, I'm a physical therapist. I graduated from the University of Findlay with my doctoral degree in physical therapy back in 2014. I'm originally from the area. I grew up riding and competing in various English disciplines throughout this area as well. And this is my mare right now, my 15-year-old off the track thoroughbred. Her name's Carrots. A little bit about me professionally. I have practiced in and managed several outpatient orthopedic clinics throughout the area. I have a lot of experience with essentially anything and everything in the body from head to toe. A lot of TMJ and headache issues, neck, back, shoulder, anything through the spine, down the legs. But I specialize more than anything in kind of chronic issues, complex issues, and a lot of nerve pain as well. So the business that I created about 3 years ago now in 2023, I offer traditional physical therapy that you would think of for chronic pain, like I said, kind of new injuries, preoperative, postoperative type stuff. One of the big things was starting my practice that a gap that I wanted to fill in a lot of physical therapy clinics. You know, you go for like your aches and pains, say you hurt your shoulder or something, and you can only lift it this far. By the time you graduate therapy, you can lift it this far. They're going to discharge you. But what if you can't necessarily do everything in your life that you want to do? It's not considered medically necessary typically. So they would discharge you and just say, figure it out on your own. So that's where I kind of try to fill that gap of people who are functioning very well, but still, you know, whether it's us working with horses, people golfing, hiking, any sort of recreational type performance training I help with. And then obviously, given my history with riding and my knowledge of the human body, I've kind of developed an equestrian performance program where I help equestrians, people who have pain like during or after their rides, or even people who just want to improve their performance in the saddle, where they notice, hey, I'm always stiff going one direction with my horse, or I've hit a plateau and I'm just kind of stuck. What can we do about that? So let's kind of get into the meat and potatoes of what we're going to talk about today is the pelvis. So let's first start kind of talking about the anatomy of the pelvis a little bit, just so we can kind of orient ourselves some. So these are the bones of the pelvis. So the pelvis is not just one bone, and it's a structure of like the sides of our pelvis, our hip, as well as our spine and our sacrum. So we have the sides of our pelvis here, kind of where you can feel your hip bones when you place your hands on your hips. That's called the ilium. And we'll kind of break down too. Those are really important, kind of looking at what types of movements our pelvis can and cannot do. And then we have kind of our seat bones down here. That bone's called the ischium. In front of the ischium, on top of it, is called our pubic bone, right through here. As you can see, our hips kind of come right into the ilium. We have our sacrum, which I always say is kind of shaped like our hand a little bit. We have our sacrum through here. And then attached on the top part of our sacrum, because our sacrum's the bottom part of our spine, we have our lumbar spine, and then the rest of our spine and trunk up above it. So these pictures didn't really come through the best here, but you know, in order to hold everything together, these are the ligaments of the pelvis. So a common question I get a lot is like, what's the difference between a ligament or like a muscle and a tendon? So a ligament connects bone to bone and provides stability. It still is flexible enough to provide the mobility that we need for the movements that we need. But like I said, this is what's going to kind of hold us together a little bit here. Now, as you can see, there's a lot of ligaments in our structure of our pelvis. It's a very stable area of our body. But some of the bigger ones that I like to kind of point out is our sacrotuberous ligaments that goes from our sacrum to our ischial tuberosity or our seat bone. That's a big one that can kind of get a little fibrotic in anybody and everybody, but specifically in riders. And then along with that, we also have kind of our sacrospinous ligament that comes across this way as well, because that's an area that gets beat up in us riders a little bit. Okay, so the muscles of the pelvis. Now, I will say one thing I did not include in this presentation, because that's a whole nother presentation in and of itself, is the pelvic floor. But we want to kind of envision too that we have kind of these muscles that come under here to support us as well. But like I said, that's a whole nother hour-long discussion kind of talking about that. So we're just going to kind of get a brief introduction to some of this. But the big ones I want to kind of point out through here. So this is looking at our bodies kind of from the side here. So like our gluteus maximus muscle kind of in our butt here that does hip extension, and our hamstrings in the back of the leg play a really important role into how our pelvis is tipped forward and backwards as well. This is the back of the leg here. These are the more superficial muscles. So we have our gluteus maximus, our booty muscle up here, our hamstrings through here. But then if we cut that back up top here, one really important muscle that lies underneath the gluteus maximus muscle is our gluteus minimus. And that's important. So that muscle brings our leg out to the side. So we call it hip abduction. But what's most important, the other action it does is when we stand on one leg, it keeps our pelvis level. So if we are weak, so if I'm standing on my right leg and I'm weak in my right gluteus medius, I'm going to drop. So you've probably seen some people who kind of get the catwalk walk where they kind of drop their pelvis a little bit. You don't normally see it like that. If you kind of like look around, what you'll typically see is someone who's only weak on one side, where they're only dropping one way. But that's super important, again, kind of for our day-to-day, but especially in the saddle with keeping our pelvis level as well. The other little muscles that kind of get forgotten about that are super important are the muscles that rotate our hip. So those, as you can see, they lie deep. So we kind of cut back all these layers through here. And they're teeny tiny muscles that go from our, what we call the greater trochanter on our femur to our sacrum. So it rotates our femur kind of in and out this way. So as you can imagine, when we're in the saddle trying to kind of function with either closing our thigh a little bit more, opening up our thigh a little bit more, those have to be strong. They have to be soft and supple. And we also have to have good muscle coordination with them as well. This image here is from the front. So this is kind of the front of our pelvis here and the front of our spine. Now, the one thing I want to point out here, it's not necessarily a muscle that kind of attaches to the pelvis, but just kind of this whole area through here, is we have our psoas muscle, or one of our main hip flexor muscles. So it's down here, it attaches to the femur where it's going to bring our leg up. But it also, what a lot of people don't realize is it actually cuts through our pelvic cavity, cuts through our tummy, and attaches to the bottom part of the spine. So everyone knows, like, when your hip flexors get tight, you know, you have a hard time extending your hip backwards. But what happens is when you try to force that, if you're tight, you're going to be kind of pulling your spine forwards as you go backwards. So it's really important to kind of keep that in mind too. Okay, so the functions of our pelvis. And again, this is just kind of like the normal day-to-day functions for our pelvis, not necessarily related to riding, but I'll kind of tie this all in together. So the pelvis is a bony cavity that's going to protect all of our visceral organs that's within the pelvis. So we have, you know, our bladder, our lower digestive tract. For females, we have some other organs in there, like our uterus and our ovaries. It protects all of that, keeps it all containerized a little bit so they're not just floating around inside of us. A huge function is it bears the weight of our upper body when we're sitting or standing. So it helps to distribute the force of our upper trunk through our lower body and through our seat evenly, so we don't kind of get pinpoint pressure in one area or another. And I kind of already touched on this. So transferred weight from our trunk through each leg evenly when we're standing upright. Muscle attachment for, like I mentioned, our pelvic floor, our core muscles, and then the muscles utilized in propelling ourselves. So our muscles that we use to have to walk, jump, run, anything like that. And one of the biggest things too is like when we are walking and jumping and running, to distribute force evenly through our spine. So when a lot of times I see when people have a lot of chronic back pain, and even honestly neck pain, and sometimes actually into the shoulders, I will notice that their pelvis is super rigid. So if our pelvis is rigid and not able to absorb the shock of just kind of taking a step and walking or whatever we're doing throughout our day, our everything kind of gets bound down up our spine, whether it's in our low back or neck, and like I said, even distributed out to the shoulders. So what we want is we want this area of our body, our pelvis, to kind of distribute as we take a step with one leg. Instead of it just drawing up through our spine, we want it to kind of evenly distribute up and through our body so it's not so jarring onto the fragile spine. Okay, so that's about the anatomy of the pelvis. Now, how does this anatomy transfer into movement? So the movements of the pelvis, we have kind of an anterior and a posterior tilt, and we'll kind of get a little more into details of all of these. So kind of tilting forward and backwards this way. We have a lateral tilt where we're tilting kind of up and down this way. And then we also have a forward and backward rotation. So like when we walk, and again, I'm exaggerating all these movements, but they all happen at kind of a minimal level when we're walking and going about our day to day. And they all also happen actually at a larger level when we're on the horse, trying to kind of help them through some movements as well. Okay, so specifically the anterior and posterior tilt. So you can see kind of through this animation here. So if this is neutral, let's do anterior tilt first. Anterior tilt is where the front part of our pelvis, so where you can kind of put your hands on your hip bones here, it tips forward some. So that can cause, you can see in this diagram here, so this is if you were to be looking through it sideways, that we get this arch through our back a little bit. Our sacrum and our tailbone kind of pop up backwards some, and our hip flexes some. So in order to have good anterior tilt in our pelvis, it requires hip flexion. So if our ilium is tipping forward, that's going to close. There we go. That's going to close the angle of the hip a little bit here. I don't know if you guys can see that. Versus standing in neutral here, you're closing that hip angle and flexing it some. So if we're tipped anterior and closing that angle here, if our spine didn't extend backwards, we'd all be walking around like this a little bit if we had anterior tilt. So in order to stay upright, which is the number one thing our brain wants to do, we have to extend our spine a little bit. So to even achieve anterior tilt, we have to have these two motions, the hip flexion and the spine extension. And then posterior tilt, you're going to get the opposite. So the top of the pelvis, the ilium, is going to come backwards. The pubic bone and the ischium are going to come forwards. And then our sacrum and our tailbone is going to kind of tuck underneath of us a little bit. And you'll see this spine up here is a little flexed forward. So if this is neutral and we're posteriorly tilted, you can see that opens up our hip angle here a little bit. And then again, if I'm posteriorly tilting here, if I don't flex my spine a little bit, I'm going to be walking around like this, which you don't typically see people walking around like that. So what can happen with this is we can, number one, we can have both sides of our pelvis that can be stuck in anterior rotation or posterior rotation. But we can also have is where one is stuck anterior and one is stuck posterior, where a lot of times I see that where it's very common where people are kind of rotated to the left a little bit. So they're stuck in anterior rotation on the right and posterior rotation on the left, very slightly. And typically, so say you're stuck in anterior rotation, usually you're stuck in anterior rotation because you don't have good mobility for posterior rotation or posterior tilt. And when it comes to riding, when we're trying to stay with the horse, for each gait it's slightly different, but we're all going to be kind of transitioning into from anterior to posterior rotation. So if you're stuck in one and stiff going the other way, anytime you try to transition while you're riding, you're going to be kind of blocking the movement of your horse's back a little bit. Okay, so lateral tilting. So again, we're here. So that's where you're going to have one side of your pelvis that's higher than the other through here. So kind of the people, how I'm standing right now, where I'm standing with most of my weight on my left leg. My left side's a little higher. My right side's kind of dipping down a little bit. If you see when people kind of stand, and we watch for this in our horses too. Do we always favor one side over the other? Do we equally switch side to side just because, you know, it gets fatiguing standing for a long period of time? Those are some things, again, we watch for in our horses. We need to kind of start watching for in ourselves a little bit to see what kind of habits and behaviors we have with that. But anyways, so what we're going to need to perform a lateral tilt. So if you are, let's say, high on the right side, low on the left side. It's kind of hard with this diagram here. I need more hands. I wish that guy was a little more mobile. He's very stiff. He does not distribute force very, very well. This one distributes force very well. It's just a lot of hands to hold. Okay, so let's say you're dipping, you're going high on the right side and low on the left side here. So when I go, you can kind of see it on my left here, on your guys' right. So when that side goes down a little bit, this hip angle opens up. So you start here in this neutral. So that's hip abduction. And then the other side, so if this is neutral and we're dropping down this way, see how it closes that hip angle? That's hip adduction. So the hip's kind of closing that angle a little bit. So again, we're not all perfectly upright with everything we do throughout the day. We kind of teeter-totter in through both directions. And sometimes when we're riding, we are kind of putting ourselves, you know, if we're doing lateral work, we're putting ourselves in some of those positions. So again, if we don't have good hip abduction or hip adduction, that's going to kind of prevent us from being able to kind of smoothly transition side to side, or even be able to ask our horses to do the correct lateral work as well. And much like with the anterior and posterior pelvic tilt, we were talking about, you know, if I'm anterior, it's going to push my spine forward. I need that extension to stay upright. Same thing with side to side. So if my right hip is higher and my spine doesn't kind of bend to the right to keep me upright, I'm going to be walking around like this all day, which, again, you don't typically see. So you have to also then have that side bend through your spine to kind of compensate for that a little bit. So you can kind of start to see how much not only the pelvis, but the hips and the spine all have to work together to be able to perform these movements. Okay, so these are kind of top-down views for hip rotation, or I'm sorry, pelvic rotation. So again, as we're walking, and especially as we're riding, we're getting kind of a slight rotation side to side. And again, we need our spine, our hips, and our pelvis to all work together to achieve these motions. So if you take a step forward with your right foot, you're going to be kind of rotating towards, your whole body and spine is going to be rotating towards the left. So with that, what you're going to notice is as that right side of your hip comes forward, or right side of your pelvis comes forward, your hip has to kind of open up an external or lateral rotation a little bit. The opposite hip, so if that left side goes backwards, your hip angle's closing and internally rotating a little bit. You might be a little easier to see it on this guy here. This, we could probably do some pelvic rotation with him here, even though he's a little locked down. So if he's rotating, he's taking a step this way to rotate to his left, step forward with the right, bringing that right side of his pelvis forward. If his feet would be stable on the ground here, he's opening up that hip angle a little bit and rotating externally. Over here, he starts in the middle and he rotates. See how that hip has to rotate inwards to achieve that pelvic rotation there. And then same thing with the spine too. So again, he's very tight through here, so you can kind of see as you take a step forward with your right, see how his whole body's moving side to side. You don't typically see people walking like that. And we don't typically see people riding like that either. So our spine has to also have a rotation to kind of compensate side to side. And a lot of times what you'll actually see is someone will have good rotation one way and not so good rotation the other way. So that's where you'll see kind of someone keeps bringing their, say, left shoulder back and the right shoulder doesn't come back quite as far. We'll see that asymmetry a little bit. Okay, so I kind of already touched on some of this throughout, but what is actually required for riding? when it comes to our pelvis. So we need all three of these things. So we definitely need mobility of the pelvis, mobility of the hips, and mobility of the spine. We need stability. So we need the stability that all those ligaments that you saw earlier kind of give us, as well as the stability of the muscles kind of holding everything together for us to be able to perform these movements in a controlled manner. And then we also need the control. So more of kind of the neuromotor control, because a lot of what we do through our pelvis, specifically when riding, because a lot of times most of the times people live their day to day where they're kind of walking around, sitting on their pelvis, sitting in the car driving. They don't really have to think about the position of their pelvis, but when it comes to being in the saddle, we're overthinking our position in the pelvis and what exactly we're doing with it, because our pelvis is so important, as we all know, to communicate. Our seat's so important to communicate with our horses and what we want them to do. So we have to be able to control those movements on even such a minuscule level. So in regards to mobility, we want to make sure that we have a symmetric range of motion through all the levels of the hips, the pelvis, and the spine. So we want to make sure that we have rotation to the left, to the right. We want to make sure we can equally go forward into anterior rotation, backwards into posterior rotation. We want to make sure we have our hip ab and adduction, and our pelvis can go up and down symmetrically on both sides. We already kind of touched on everything with the stabilities. We want to make sure that we have the ability to maintain these movements, whether it be bilaterally or even unilaterally. So again, like if we're asking our horse to do some lateral work, we're going to have stability on one side over the other a little bit. And then again, control. We want to be able to control going into and out of these positions a little bit. A huge thing that I work on with clients after we get the mobility of all the components, the stability of all the components, is being able to disassociate our spine, our pelvis, and our hips appropriately. Because sometimes what happens, especially I have a lot of riders who have desk jobs. And what ends up happening is the hips, the pelvis, and the spine, they all want to move together as one unit. We have to be able to separate out the rotation of the hips, the ab and adduction of the hips, we can't really tip him, the tilt of the pelvis, and the movement of the spine. If we're not able to do a motion and have it just come from our hips, or just come from our lumbosacral area here, or just come from our pelvis, we're not going to be able to give our horses kind of like the finite cueing that we need to get specific movements from them. Okay. So with these three things, when do we typically notice that there's going to be issues, specifically for riders? So with mobility, so hypomobilities, hypo meaning low, so low mobility at the level of the joints, ligamentous structures, or the musculature. And the other thing too, I didn't add in there too, the nerves also can be hypomobile as well and cause some stiffness. So we want to make sure, so if we're working on, anterior and posterior pelvic tilt here, I always start at the joints. Can the joints even move? Because if the joints can't move, there's no use in stretching or strengthening the muscles because the joints don't even have the movement that we need. After we get the joints moving, then we say, okay, well, can the muscles move these joints through the appropriate movements? And if they can't, is it a muscle issue? Is it truly a strength issue or a coordination issue? Or is there a ligamentous structure kind of holding us back? We have to kind of look at it from all angles, because if we were to just focus on stretching the muscle till we're blue in the face, that's not going to help us if we have a ligamentous issue or if we have an issue at the level of the joints. So it's very important to kind of look into all of that. And then with mobility too, we kind of touched on a few times, is asymmetry. So again, people who are in their day-to-day, everybody, you can pick any random person up off the street, everyone's going to have some sort of asymmetry. It doesn't typically affect a person just going through their day-to-day unless it's a very exaggerated asymmetry. However, in the saddle, we need that symmetry. So we're kind of a different group of people where symmetry is a lot more important to us than it would be for your average person. When we experience issues with stability, so instability. So essentially what instability will be is people who have more lax ligaments, people who have more lax tendons and muscles as well, or people who have kind of more of a muscle weakness. Now there's a generalized muscle weakness just kind of throughout, or kind of pinpoint. Are you just weak through, maybe your external rotators of your hips? Are you weak through your hip abductors, which is probably the most common that I see for anybody and anybody and everybody? Or hyper meaning exaggerated, so increased mobility and ligamentous laxity. So there is a group of people who are typically hypermobile. So everyone's a little different with how much collagen they have in their ligamentous structures, or they have in their tendons as well. Some people are hypermobile where they're prone to dislocating joints, kind of having more strain on like the ligaments and the tendons as well. That is a very specific group of people. And I'm not saying it doesn't happen, because I do see it actually quite frequently, because I do tend to see people with more kind of complex chronic issues. But it's very important to differentiate between people who are systemically hypermobile, which I have some tests to kind of run people through for that, versus you're just kind of hypermobile in certain areas because of a specific ligament issue or specific muscle issue, or even an injury to a joint. And then issues with control, so lack of neuromuscular control. We've all experienced this when we're riding and our instructor wants us to kind of do something with our seat and our pelvis, and we think we're doing it and we're thinking really hard about it, and we just can't. Like, it's just not translating into the saddle. So sometimes there's a little bit of a lack of communication from our brain to our muscles in telling our pelvis in our joints what they want it to do. So that's something I work on with people all the time, is that control. Is our brain truly sending the right signals to those muscles, and are the muscles receiving it well? Because especially if it's a muscle that we just don't use, our brain is actually a very efficient structure in our body, where if we're not using something, it's just going to kind of, oh, that's not important. I'm not going to communicate to that area as much. I'm going to focus on these other areas that I do work with more. So sometimes it's even just kind of waking up that communication a little bit. And then again, very importantly, I already kind of touched on, is disassociating the spine, the pelvis, and the hips appropriately. And can we consciously think and do that a little bit? Can we say, okay, I'm going to bend forward, but I'm going to bend forward from my hips, or I'm going to bend forward and I'm going to bend forward from my spine here a little bit? Can we consciously have our body do that? So when I'm assessing somebody in looking at their pelvis, and again, I do this with a lot of my clients, but I do this assessment with every single one of my riders. I need to know that what we're sitting on, what we're communicating to our horse with, is functioning appropriately before we go on to anything else. So I will always look at in standing posture, and then also laying down, kind of where the pelvis is sitting. I look at the mobility, the gross mobility, gross meaning, the big movements of the hips, the hip extension, the hip flexion, the hip rotation. And then also do we have the muscle strength that we need in these areas? But the most important thing is kind of the pelvic mobility, where you can see I'm kind of, and this, I'll demonstrate this, and this is also what you guys will get to experience at the end too, where I test the actual mobility of all these joints. Does our hip rotate in and out? Do we have anterior and posterior tilt on both sides? Does our pelvis kind of, at our ischium, at our seat bone, does that move forward and back? At our sacrum, does our sacrum kind of rotate side to side? Does it rotate up and down? So do we have the mobility everywhere that we even need at a physiologic level? Okay, so before we move on, would anyone like to volunteer so I can kind of demonstrate kind of what I do when I assess the pelvis, and also what we'll do at the end? Heather, come on up. I appreciate it. Yeah. This is my friend Heather. Okay, so I'm gonna have you face this way so everyone can see you from behind. You okay with that?
Yep.
Okay. And I'll kind of turn my dude this way so you guys can kind of see at the bones what I'm feeling for and looking at here too. Okay. So I always start at kind of looking at someone from behind here. And I always find kind of what we call the iliac crest, the ilium through here, and I put my hands on that. And a lot of times I kind of close my eyes because I don't want my eyes to play a trick on me. I just want to feel what I'm feeling here. Oh, we need to work on this. Okay. So I don't know if you guys can see, but she's very high on the right, very low on the left. So I'm on her kind of right here is what I'm feeling for. Actually, I'm kind of at this angle here. So she's a little off kilter through here. So high on the right side, meaning, so again, as we kind of talked about some of that physiologic motion that happens at the joints, she's high on the right, low on the left, meaning this hip's probably sitting in a little bit of adduction, and this hip's probably sitting in a little bit of abduction, just in her normal day to day. So that's something that we'll have to kind of take a peek at. Then I'm gonna have you turn this way. So what I'm gonna look at now is the front part of her iliac crest and the back part. So we call this the ASIS and the PSIS, anterior and posterior iliac spine, in case you guys were wondering. So what we want to see is that, I mean, he's a little anterior here, so we want to see that my my finger in the front and the finger in the back are slightly off kilter. This is a little exaggerated, so quite frankly, I would say this guy's a little anteriorly rotated. So usually we would see it kind of being just off kilter a little bit, or if it's level, that's posterior rotation. Okay, so let's see where you're at here. So this is what we want to see. So she's just slightly higher in the back than in the front. I would say that's pretty neutral. All right, go ahead to your other side. And same thing here. She's pretty good there, for sure. Okay, go ahead and face that way again. The other thing too, I look at in standing. Now I always check this laying down too, but I always just like to see, because sometimes it's very obvious with people, is their pelvis truly in the center of their body? Which if anything, she might be slightly to the right, but again, I test that with mobility more than anything. I'll look at the spine too. So how does the spine kind of tie into the lumbar spine, tie into the sacrum? If somebody's anteriorly rotated, we're typically going to see they're extended through their spine, versus if they're posterior, we're going to see they're a little flattened. And then I also look at, are they stuck in a little bit of side bend one way or the other? And she's pretty good there. A little bit of like what we call lordosis, but that's actually normal. We want a little resting lordosis through there as well. Okay, I think that's all I was going to demonstrate in standing. Yep. Okay, so let's have you, if you don't mind, I'm going to have you lay on your tummy. Okay, so from this position, now you guys probably won't be able to see that from there. I think I'm just going to scoot your coat on this side of the table. As I look to see, when someone lays down on their tummy, is one side of their pelvis higher than the other. And so what that shows, so pretend he's laying on his stomach here. If his left side is higher than his right, his whole pelvis is rotated towards the left, and vice versa. So that kind of clues us into what's going on at the level of the pelvis and at the level of the hips as well. So with you, you are slightly higher on the right compared to the left. So you're a little like this through here. Now, you know, I always kind of keep in mind too, like, is this truly that a structural thing with the pelvis, or is it more of like she just has more muscle tone on one side or the other? And if that's the case, that's still something to be addressed. But I always kind of keep that in mind as well. I'm going to test the rotation of her hip. So I'm going to come on her, what we call the greater trochanter, which is this little, well, big nubbin on the side of the femur here. And I'm going to see, does this rotate? Does this rotate forward? And does it rotate forward the same on the left that it does on the right as well? Okay, I'm going to give you a little pressure. So I would say that feels a little stiff, but let's compare to the other side to see what her normal is. Feel the difference there? So she's got a lot more movement on the right side of her hip versus on the left side. You guys actually might be able to see it. You can see how much she rotates this way versus that just stops right there. Which means her trochanter is stuck a little external here. So I'm trying to push it forwards and you're stuck kind of out this way. Okay. What else was I going to do for you guys today here? Because believe me, we could spend a lot of time here. I tried to kind of make it a little succinct for everybody. Oh, the ischial tuberosity and pelvic tilt. Okay. So go ahead, lay flat again. Okay. So I tested the trochanter in the hip. Now I'm going to put pressure forward on her seat bones. So how does her pelvis move forward on both sides? Okay, I'm going to give you pressure. And I'm going to give you pressure. You're a little stiff on both sides, I would say. Maybe a little bit more on the right here. But yeah, her pelvis doesn't really want to move forward on both sides, meaning there's tension going forward. I'm going to give you a little pressure on your sacrum here. So this is not something I included in for the demonstrations today, but what I also will look at is the movement of the sacrum, where I'm pushing center. Does this whole sacrum move forward? A little left, does it rotate? A little right, does it rotate? You are a little stiff on your left here. Yeah. So feel how there's movement there? Not as much there. Okay. So the other thing I'm going to assess for everyone today is the tilt of the pelvis. Does the pelvis tilt on each side anteriorly? Does it tilt posteriorly? So she's laying on her stomach here. I'm going to try to mobilize this ilium, her left ilium first forwards. Does it rotate anteriorly? And then I'm going to compare the other side. And she's pretty darn good there. Maybe slightly more stiff on the left, but that's me being picky. Not bad there, but we already saw in standing she's pretty neutral. Let's go on to your back. Now what I'm going to do is I'm going to do the opposite. So I'm going to come on her anterior ASIS here and try to posteriorly rotate and compare side to side. I'm going to give you pressure here. Sometimes people can be ticklish here. So that has very good spring to it, very good give to it. And so does that. So you move very, very well. So she is pretty neutral through here, just like we saw in standing. And then finally, what we looked at in standing, I said she might be a little bit shifted to the right. So I'm going to test her mobility of her pelvis side to side on both sides. So you just kind of lay there. Let me move you. So we should see a symmetrical movement side to side. So she moves very well to her right. Feel you stop there a little bit. So going to her left, she'll move to midline, but doesn't really want to cross midline. So that kind of confirms what I saw in standing, where she has good movement to her right because she's stuck that way. Her body wants to move that way. She doesn't move as well to the left. It doesn't want to cross midline to go past left there. All right, you can go ahead and stand it up. So that is the pelvic assessment that I'm offering to do for everyone today, but it just kind of gives, you guys can see, it gives us a good lay of the land as to what's going on, kind of starting at the pelvis there. Thank you. I appreciate it. Great job. Okay. So I've kind of been briefly mentioning this throughout the presentation, but how does this translate into the saddle? So number one, a lot of us has probably heard our instructor, hey, you're dropping your left hip, you're dropping your right hip's coming up, even in a static state. So like we saw, if you don't mind me using you as an example, like we saw with Heather, just standing, she's high in the right side of her pelvis. That's not going to change when she gets into the saddle. So if her instructor's telling her, hey, you're dropping your left hip, you're dropping your left hip, you're dropping your left hip, and she's consciously trying to raise it up, she's not going to, right now, that's just her natural state. She's not going to be able to raise it up without compensating. So what comes with that is, then maybe she's trying to like shift her pelvis, or her upper body then has to move. And then her instructor's saying, well, now you're dropping your left shoulder, and then you just end up kind of riding around like this. And you're like, am I doing it? Am I doing it? And your horse says, heck no, you're definitely not doing it. So if we can't even achieve this movement and this posture on the ground, how the heck are we going to achieve it in the saddle? So like I said, even kind of in a static state. And I'm not saying too, again, what we're looking for is not a perfect symmetrical state all the time. We want to be able to move in and out of it. We want to be able to start where we need to and then move in and out of it as necessary. And so kind of looking from the side too, kind of for anterior and posterior rotation, like this rider here specifically. Now, mind you, I'm not here to throw shade at anyone. She's doing a lovely job, but just I was trying to find pictures that show a little bit of how her pelvis is slightly tipped forward. So she's getting a little bit of flexion at her lumbar spine. So again, you know, her instructor may say, hey, you're leaning forward, try to lean back. But if the instructions lean back and she's leaning back this way, her pelvis is still tipping forward and she's just exaggerating that lordosis through there. So the question then becomes too, like, can that rider even posteriorly rotate enough to bring herself upright? She may or may not be able to. And it may be a mobility issue, it may be a strength issue, it may be a control issue. And that's what I help riders to kind of find out. So I already kind of mentioned some of this. We're not only looking at like a static posture on the horse, but we've kind of been mentioning this throughout. Recall the movement required for staying with the horse during each gait. So whether it's the walk, trot, canter, what we're asking our pelvis, our hips, and our spine to do is going to be kind of a different motion. You know, you got your walk motion, you have your canter motion. Those ones are similar, just at like different magnitudes. The trot is where I see a lot of people struggle with, because it's a much smaller magnitude, but there's a lot more happening with that, and there's a lot more that goes up towards the spine. So a lot of times when people have a hard time absorbing shock through their pelvis, those are the riders that you're going to see kind of real stiff through their spine and just kind of bouncing on their horse's back a little bit. Successfully steering with your body through turns. So a lot of times too, I have riders, you know, oh, I have such a hard time. My horse doesn't like to bend to the left, or my horse doesn't like to bend to the right, or every horse I get on, I struggle to bend to the left or bend to the right. Could be a horse problem, you know, could be a saddle fit problem, could be a chiropractic problem, could be a symmetry problem on the level of the horse, could also be us. Probably is a lot of us. And I had an instructor one time always tell me that sometimes my horse and I would have a old married couple syndrome, where, you know, one kind of compensates for the other, one kind of knows how to push buttons for the other, and vice versa. And that happens a lot of times with our bodies and with their bodies. A lot of times what they have going on is a direct reflection of what's going on with us. So we will jump to getting the saddle fitter out, chiropractic, vet, doing red light therapy, doing beamer, doing this, doing that for them. We don't even look at ourselves. So a lot of times in order to be able to get them to bend and move laterally the way that we want them to, we can't even do that. So we need to look at ourselves for that. And going along with bending, asking for leads. So if you're struggling getting a right or left lead on your horse, maybe kind of sit and think, am I even cueing them correctly? Do I even have the mobility, the strength, and the control to be able to ask for this? Same thing cueing for lateral work. Cueing for increased hind end engagement. So we know if we want their back to be nice, soft, and supple, but we're asking them for a little more for their hind end, can we even stay with them? And can we even ask them with our seat and our bodies to increase or decrease their hind end engagement? And same thing with increase and decrease backswing too. We want to make sure that we can maximize what they're able to do so they can do what they need to do in a healthy way. Sometimes we may be holding them back a little bit. So why do we have these issues with our pelvis? Like, where does this come from? So number one, everyday life, 80% of people who have issues in through their pelvis, their hips, and their low back will have what we call left rotation fixation. So that's where you'll see people are typically slightly shifted to their right. Now I'm going to exaggerate just so you guys can see. Shifted to the right. Right ilium is rotated anterior, left ilium is rotated posterior. You have a rotation at your sacrum, you have a rotation at your spine, and you have a tight left hip through here. So a lot of people are walking around day to day like that. And the reason for that is the world, regardless of our own hand dominance, is built for right-handed people. So when we go to shake someone's hand, when we go to open up a door, a lot of things are encouraging us to kind of rotate this way. The world is just built asymmetrically. Our daily habits, daily postures, daily patterns. So workstation setup is a big thing for people who have desk jobs. A lot of times nowadays, people have multiple monitors. Do you have one monitor in front of you and then one slightly to the right? So all day long, you're getting the slight right rotation, but are we rotating to the left? People who have jobs where they're maybe on the phone and they tend to kind of hold the phone one side, hold the phone to the other side, leaning their whole body one way or the other. Sleeping posture, sitting posture. My big thing, because a lot of what I do, so I have in-office appointments 1 day a week, but the rest of the week I'm traveling, I'm mobile. So I find myself, I'm driving, I have my coffee and my water, my radio over on this side. So I find myself like this a lot. So then I'm like, oh my gosh, no, now I have to sit this way, or I have to, 10 and 2. So just even things like that. So kind of pay attention to what you're doing in your day to day. People, a lot of times at the end of the night, if they're watching TV, is your TV right in front of like your couch or recliner? Or are you slightly one way or the other and you're sitting there for like an hour or two at the end of the night? So just paying attention kind of what you're doing that could be predisposing you to that a little bit. Muscle imbalances. So muscle imbalances being front to back or left to right. So if we are front to back, meaning if someone's stuck anterior, their hip flexor muscles, the psoas muscles that attach to the spine, and then there's also one called the iliacus that attaches to the front part of the pelvis here and to the femur, that's pulling you forward. You're stretching your hamstrings the whole way. So you have tight hip flexors, weak glutes and hamstrings in the back to be able to pull you backwards, and a lot of times a weak core. Now, if someone is posteriorly rotated, you're going to typically find they have very active, tight hamstrings because those attach to the ischial tuberosity here, your seat bone, pulling you there. And then weakness in through the hip flexors and tightness in through the core a little bit, kind of pulling you into this position a little bit too. So that's kind of the imbalance we can notice front to back, all things we can address. And then also side to side. Are we having asymmetry side to side where you're anterior on the right and posterior on the left, high on the right, low on the left? We already kind of talked about that, the catwalk where you're going to have dip on one side of your hip versus the other. So that can predispose us to some of these pelvic asymmetries and pelvic issues as well. This is a really big one, compensatory movement patterns for other injuries, and not necessarily injuries just to the hip, the pelvis, the low back. If someone has a foot injury, if somebody has a knee injury, a lot of times even like a shoulder injury where you're favoring yourself on one side or the other, that changes how we're moving day to day. A big thing I see is if someone has to be in a walking boot for a long period of time, say you're in it for 4, 6, 8, sometimes 12 weeks, that's going to throw everything going up off. They do fortunately have products and stuff now that help with that, but that's something that's kind of, when you have an injury, it's kind of unavoidable. So that's a lot of times something people have to work through after the fact. But again, a traditional physical therapy clinic is going to be like, oh, your foot's better, so bye, see you, bye. But they're not going to say, okay, well, their foot's better, but what did that change at the knees, the hips, the pelvis as well? And let's address that. Our own horses' asymmetry. So they come with their own baggage, just like we do, and we have to compensate for that. So again, sometimes if we're so used, especially if we only ride one horse, and we're so used to compensating for that one horse, and then say we go to get on another horse, and that horse is like, what the heck? Like, you can only move this one direction, but it's because this whole time you've just been kind of trying to support your own horse. So that can cause us to also be asymmetrical. And then structural issues. So especially in through the hip, everyone, we're relatively the same on the inside, but everyone has different kind of structural anatomy. So like the angle of our femoral neck through here, so where the head of our femur hooks into the side of our pelvis and our trochanter here, your angle can vary very differently. The angle of the socket that the head of the femur goes into here, that angle can vary differently. So from person to person, there's going to be certain structural things that they have going on that we can't necessarily change. And we don't want people to go and have surgery to be a perfect specimen, because that's not possible. What we have to do is we have to recognize that and then be able to say, okay, here's what your structural anatomy is, what it's allowing you to do and not allowing you to do. How do we manage that? How do we mitigate that going forward? And how do we help your body through that? Okay, so how do we address these issues? Working with a physical therapist. But first things first is we have to determine what the issue is. So again, we said, is it a lack of mobility, a lack of stability, or is it a lack of control, or all three of them? And then if it's a lack of mobility, is it a lack of mobility at the joint, the muscle, the ligamentous structure, or even the nervous system? Which again, that's a whole nother discussion, so I kind of kept that out of today. If it's a lack of stability, are you truly hypermobile? Is it a muscle weakness? If it is a muscle weakness, which muscles do we need to work with? And then also a lack of control. Can we disassociate our back, hips, and pelvis from one another? Can our brain actually truly send the correct signals to those muscles? And then we can go and address that. So how do we address all these issues? So with a stability issue, with a mobility issue, we'll do low load, long duration stretching, kind of work on stretching out joint capsules, ligamentous structures, because again, the pelvis has a lot of big, thick ligamentous structures we have to kind of work through. A 30-second stretch is not going to do that for the ligamentous structures of the pelvis. Mobilizing the joints themselves. So the joint of the hip through here. I don't necessarily have it does happen, but not too many people. We have to mobilize the pubic bone joint, sacroiliac joint, or SI joint, which as horse people, we've all heard of our horses having some issues there. We also very commonly have issues there. Is it segmentally and through the spine? And again, is it through the ilium as well? So we can mobilize all those joints, and there's a whole toolbox of techniques we can use to improve that joint and soft tissue mobility. Strengthening the specific weak musculature, stretching the specific tight musculature, and then neuromuscular reeducation to improve our movement patterns. And then too, when we determine specifically, oh, your issue is you're stuck anterior on the right, and that is your biggest issue, or your biggest issue is your whole pelvis is shifted to your right, then we kind of play investigator and say, okay, well, why is that? Is it something in your day-to-day that's doing it? And if that's the case, that's an easy fix. We can kind of investigate, figure that out. You change that, hopefully you should be good to go. So these are all things, all in a combination with one another, that we need to address our pelvis, hip, low back, so it all can work together as one unit. So what can you do today? Leaving here today, what can you do now? Like I already kind of touched on, kind of pay attention. What is your normal sitting posture? What are your normal day-to-day habits? What's your normal standing symmetry? Are you noticing you're doing something that's asymmetrical throughout your day? And then, like I said, what we would do if we were working together is I would kind of pinpoint exactly what the issue is, and we'd give you 2 to 3 stretches to pinpoint that exact issue to give you the most bang for your buck. But exercises most every rider can benefit from. Well, we're going to go through those just kind of real quick. You have all of these in your handout too. So anterior and posterior pelvic tilt. Oh no, he lost a foot. We'll fix that. We'll do surgery later. So anterior and posterior pelvic tilt. So in your handout, I have it where she's laying on her back, and working. You're picturing you're having a clock, and you're going from 12 o'clock to 6 o'clock with your pelvis, kind of bringing it forward and backwards. The reason I like people to start it laying on their back is because it keeps your spine accountable. So again, if we're stiff through our pelvis and we try to, in sitting or standing, go to anterior and posterior, you're going to get this, or you're going to get this, which again, you probably see a lot of people ride like this too. If you want to be stable up through here, you got to be able to disassociate that. So starting laying on your back, keeping your spine on the table, and just getting that slight movement, anterior and posterior. Start here and then progress to standing, then progress to the chair and in the saddle as well. So I do like to give a lot of my riders that as kind of like a warm-up stretch, getting on your horse and just kind of exaggerating the anterior and posterior until you kind of loosen yourself up a little bit. Gluteus medius strengthening. So we saw kind of that catwalk where you have one hip dropping. In the handout, which exercise, I mean, there's a million exercises for all of these. So I have kind of laying on your side, bringing your hip out to the side. And again, I'm just going to go over these real quick. The biggest thing with this is a lot of times, because people get so tight in the front of their hip, when they're doing this, their hip comes forward because they're so dominant in that hip flexor, but they're not strengthening this gluteus medius through here. So you want to keep your hip, if anything, slightly back and then up and down. So you're not going to have as much movement, but that's not what's important. What's important is you feel kind of the burn through here a little bit. So that's hip abduction. And then a hip flexor stretch. So stretching kind of the front of the hip out. I'm going to borrow one of these chairs here. So again, the hip flexor goes top of the femur onto the pelvis, up and through the spine. The leg you're stretching is the leg on the ground. You're going to put one leg up, whether it's a chair, a step, a couple of hay bales, probably one hay bale. Bottom foot, you want to make sure your toes are pointed to the surface you're stretching on. If it's out at all, you're going to be stretching the inside of the thigh, not the front. And then again, we want to elongate this area. What you don't want to do is lean your shoulders forward because you're compressing it. Keep your shoulders back, hips forward. What you'll notice, that'll give you a big arch through here, sometimes discomfort. So what you're going to think is you're going to think a posterior pelvic tilt, flattening your low back, kind of engaging your core. You're going to feel a bigger stretch here, and you're going to take the pressure off your low back. I usually tell people like 45 seconds to a minute for that stretch to, again, allow all the biggest ligamentous structures to stretch out as well. And I know we're going through these very quickly. If you have any questions on them, feel free to ask them afterwards too. I can address that. So not only do we need to stretch the hip flexors, it's very, very important. Research now is saying that a lot of times people's hip flexors aren't functioning because they're actually weak. So a strengthening exercise for it. You can take a book, a yoga block, kind of whatever you have access to, an orange, one of the small orange cones. So you're going to sit up and over. And then you would do that kind of on both sides as well. And make sure that you're isolating the movement of the hip and not compensating kind of with the back as well. All right, what else do we have here? Oh, this is a good one. This is a super one, actually. So hip rotation, super important in the saddle. Now this one, it's a tough one. It's very important, but it's tough, tough, tough. So to make it easier, I can only do it so much on this table here. The further back you lean your upper body, the easier it'll be. So start further back. And what you're going to do is you're just going to go side to side, making sure that you're going to have one hip that's rotated in and one hip that's rotated out. And you're just going to kind of teeter-totter. And you'll feel, okay, for me, my right hip doesn't want to come in quite as nicely as when I do my left hip. So maybe I'll hang out there for a little longer than on my other side. And then as you progress, you'll kind of get closer and closer to kind of close that hip angle there to open up the hip some. And then the final one, what did I do for you guys here? The transverse abdominis. So we didn't talk too much about the abdominal cavity, but the transverse abdominis is, we have our six-pack ab muscles, our rectus abdominis. Most superficial muscles, we have our obliques, and then we have our transverse abdominis, which is like our built-in back brace. That is very important in the control and the stability of our pelvis, especially if we have a horse that's like a big mover and we're trying to kind of collect them up and reduce the movement through our pelvis. We really want to tighten that transverse abdominis. So what you want to do here, lay on your back, knees bent up. This is the easiest way you're going to feel it because it's a tough one. I like to put my pinky on that ASIS, that pelvic bone. The rest of my fingers rest above it. And you're not going to suck in and you're not going to hold your breath, but what you're going to do is pretend someone's about to punch you in your tummy and you're bracing for it. So what you're going to feel under your fingers is that you don't want to feel the muscle in your tummy pop up into your hands. You're going to feel it kind of spread out under your hands. So you'll contract, hold for 5 seconds, and then relax. You shouldn't get movement through your pelvis or your back. You should just feel that muscle kind of slightly spread out. It's a very small movement through there. After you kind of master that and get that feeling laying on your back with your knees bent up, then you can start practicing it in sitting and then in the saddle as well. So like I said, I know we went through those very quickly, but feel free to ask any questions on those afterwards if you have any questions. Oh, any questions? Any questions on anything? I know I threw a lot of information at you guys today. Any questions at all? Sure.
I have tons, but I'll give you one.
Yeah, as many as you'd like.
I need to come and see you. So when you're doing some of these exercises, how close does it need to be time-wise to your ride to be a benefit?
That's a good question. So these exercises that I went over today, getting in the habit of just doing those in your day, whether you incorporate it into your day-to-day or even go from doing nothing to doing it 3-4 days a week, is going to be beneficial. A lot of the riders I work with, I do actually help them to come up with a pre-ride type program that's catered to exactly what they need prior to the ride, if that makes sense. It kind of just, I hate to say this, but it depends. It always depends. So it depends, like if you do suffer where your hip rotation is very stiff in the saddle, I would maybe do that hip rotation one right before you get on.
So lie on the dirty stall floor. And, yeah.
I mean, here's the thing too, and that's what I work with people. No, that's what I work with. There's other ways to do this, and there's other ways. So, for example, one stretch I do have some people do, and again, this is not appropriate for everybody. A couple of hay bales, where they're just kind of going back and forth here to get that, or even that hip flexor stretch on a hay bale. You know what I mean? And that's where we kind of have to say, okay, what does your body need exactly, and what type of environment do you have? You know what I mean? And honestly too, like even if you were to do it at home, or if you board and you drive to the barn, even if you were to do it in your house, it wouldn't be ideal because then you're sitting in your car driving for who knows how long, but it's better than nothing. Does that make sense?
Yes.
So incorporating it at any time is better than nothing, but it's always good to kind of come up with some sort of pre-ride program that's best for your body and also your environment that you have to work with as well. Great question though. Great question. What other questions do you guys have? Sure.
When you're doing the hip flexor.
With the chair?
Yeah.
Mm-hmm.
No, when you were
Oh, with the yoga block?
This, or whatever.
The hip rotation.
Okay, the hip rotation. When you flip your legs over, how?
Okay.
Sorry, Jessica.
Yeah.
She had a writing lesson.
Aww.
Let me come in just to let y'all know I'm videotaping, so we'll have it available for you.
Oh, awesome. Okay, thank you. But when you flip them over, how long should you stay there before you flip it to the
Great question. I would say 5 to 10 seconds, unless you feel like you need more. If your body's like, oh, this feels really good, and you can hang out there for even up to a minute if you want.
Oh, okay.
So there's 2 different types of stretching. There's static stretching where you're holding for a longer period of time, anywhere from like 30 seconds to a minute. And then there's that dynamic stretching where you're kind of going back and forth. Dynamic stretching is optimal for pre-activity. So if you're doing it before you ride, you would do more dynamic where you're kind of, up to 5 seconds. If you're doing it after a ride or at the end of the day, then you want to hang out there for a little longer. Does that make sense? Good question. That was a really good question. Anyone else? Sure.
Are you able to help situations where you have a structural asymmetry, like a shorter leg or like the front pelvis is higher than the other?
Absolutely, absolutely. So if there's a structural issue, what then we have to do is, okay, how do we manage and mitigate this? Specifically, you've probably been managing and mitigating it for a while now in your day-to-day, but specifically in the saddle, what do we have to do to kind of manage and mitigate that? And that comes with where we may have to do more asymmetrical muscle training, asymmetrical muscle stretching that way. But yeah, it is manageable. You're not going to change it because it's a structural issue, but we can absolutely mitigate that for sure. What other questions? No? All right. Well, thank you, everybody. I will be here. This is my information. I think you guys have some of my information as well if you have any questions afterwards. But I'm going to hang out. On the back of your handouts, you should have just like a little checklist. So if you're interested in getting kind of an assessment like I did with Heather, feel free to come up and I can kind of check off that checklist, like where you're starting at. And then you can kind of play around with some of those exercises to see what help you out.